All right, guys, so we're going to talk about chest injuries now. There's just a few injuries in particular that we need to focus in on. So the biggest thing here is going to be, is it an open wound or a closed wound? Um, Generally, a closed wound is going to be caused by blunt trauma, and an open wound is going to be caused by some sort of penetrating trauma. So a closed injury can be something like a cardiac contusion or a pulmonary contusion. So this is like some sort of blunt trauma, and that force extends all the way into the muscle tissue. Now, or an open injury, that's usually a knife, a bullet, or some sort of projectile or some sort of penetrating trauma that now opens up a hole inside the cage. Blunt trauma may cause some chest fractures, as in rib fractures or sternal fractures, bruising to the heart and lungs, damage to the aorta, or some injuries to the vital organs in that area. Some of our signs and symptoms are going to be pain, increased with the pain is actually going to get worse with breathing, and that's because as we breathe, our chest wall actually moves. So any movement on an already inflamed area is going to be pretty painful. You'll see some bruising. You might even have crepitus, and crepitus is just kind of this weird bag of Rice Krispies type feeling, which just means that there's some bone ends that are rubbing up on each other. Penetrating injury to the chest, and we'll talk more about that. And dyspnea, which just means difficulty breathing. We also are going to keep an eye out for hemoptysis, which is just coughing up blood. Something we can look for is unequal chest rise and fall. That shows something's wrong. A rapid weak pulse and low blood pressure, those both suggest some more issue, some sort of shock type issue. And if it's bad enough, they might even have some cyanosis, which means they're not breathing correctly. They're going to have rapid, shallow respirations because they can't take that deep breath. They're going to take small breaths, and they're just going to take more of them. So that's why we're going to want to listen to those breath sounds. We've already gone over that in class. So it's apex, apex, base, base. We want to make sure that we're hearing all aspects of the lung, both front and. So deadly dozen chest injuries. These are good things to be familiar with. This question specifically won't be on the test or the National Registry, but these injuries, we should be familiar with these injuries. And we will talk about quite a few of these in this presentation. Now, a pneumothorax, if we're going from med term, pneumo, air, thorax, chest. So pneumothorax is just air in the thoracic cavity. It's another name for it is a collapsed lung. Basically, it's that air has accumulated in the pleural space, and that's going to cause a lot of problems. So that's what it looks like when there's air in the chest cavity. The lung wants to expand, but it can't push against that air bubble. And as you can see, that the lungs are not going to be able to fully inflate. Now, an open chest wound is an open pneumothorax or a sucking chest wound. And that's because our whole thorax cavity is based on a pressure system. So our diaphragm creates a negative pressure, which then air flows in. So if there's a hole somewhere randomly in the chest, air is going to come in that hole as well. So we need to cover that with an occlusive dressing, which means that air cannot go in or out. So we want to prevent this. As long as that open chest wound is open, you can see here in the picture, that's exactly what's happening. Now, a spontaneous pneumothorax is slightly different. That's going to be a structural weakness. That's generally it's taller, skinnier patients who are smokers for whatever reason. That's some of the commonalities with our spontaneous pneumothoraxes. But it's basically just this little area of weakness in the lung, and it can get triggered, and now that little weakness can rupture, and now air is going to be moving. A simple pneumothorax just means that there's air in the chest cavity, and it can result in major changes, but it doesn't always result in those changes. Really, a tension pneumothorax is when we start to see major changes to our vital signs. So that's when the air has gotten so big, the air pocket's gotten so big that now it's starting to push up against other organs. And that's what we call it. So a simple pneumothorax is air in the chest, and it may not have any major changes to the vital signs. Whereas a tension pneumothorax, this is when it becomes a problem. So that's just another picture of that air coming in the chest cavity, and it's crushing that lung. Now, a hemothorax is basically just like a pneumothorax. It just means there's blood in thoracic cavity. And you can see in the pictures here, It just means that the blood is filling that chamber. So you can even have a hemopneumothorax, which means it's a mixture of blood and air, and that's just that much more complicated to treat. Normally, a pneumothorax or a hemothorax, these patients, they're going to need some sort of chest tube or a vacuum pump. They're going to need some serious hospital intervention. You cannot really treat a hemothorax in the ambulance. It definitely needs a hospital. So a hemothorax, you're going to see some shock symptoms. So you're going to see some increase in respirations and increase in heart rate, and you're going to have decreased breath sounds on the affected side because the lung's going to be trying to move, but it really can't. And so if you see any sort of decreased breath sounds on any side of the chest, that means the lung is not working correctly and they need to go to the hospital as quickly as possible. So another chest injury that's in the area of the chest is a cardiac tamponade, which really results from the heart not being able to pump effectively because the pericardium is actually full of blood. And so there you go. The pericardium is this little plastic sac type thing that encases the heart, and it really doesn't have just almost like the cranium. It doesn't really have a lot of room to deal with increased pressure. So if you have a bunch of extra blood inside the pericardial sac, the pressure really starts to build. And if that pressure builds, the heart is not going to be able to effectively pump against that increase in pressure. So Beck's triad, and that we'll talk about that next slide. Altered mental status. Now, if you have these things, really this is a hospital type thing. So we want to make sure they're breathing as much as possible, want to put them on some oxygen, and then we need to take them to a hospital as quickly as possible. So Beck's triad. These are the three things that the doctors have figured out that are common amongst this injury. So distended neck veins, muffled heart sounds, and low arterial blood pressure. If you see these three things, that's suggestive of the pericardial tamponade. So that means there's lots of blood in that pericardial sac and the heart is struggling to beat effectively. So rib fractures, this can be from blunt or penetrating trauma, but it's more commonly seen with blunt. So localized tenderness and pain when breathing. Like I said before, our chest wall actually moves quite a bit when we're breathing. So if a patient's taking nice big deep breaths and they have pain with that, it probably means there's some sort of fracture. So you're going to see rapid shallow respirations. And in fact, the patient's going to know that something's wrong, and they may even be holding that area of the chest. Now, if it's bad enough, a flail chest is where there's a few ribs that are broken. So it's not just one fractured rib, it's usually 2 or 3 fractured ribs, and they form their own little segment, their own little island of bone. And we call it paradoxical motion, which just means that there's the segment of broken ribs is going to be moving opposite of the rest of the chest. And that's because it's completely disconnected and it's doing its own thing. But just like the other injuries, we need to maintain the airway, provide respiratory support if needed, so give some oxygen, and take them to the hospital. There's not a ton we can do in the ambulance for this injury. Now for that for that flail segment, we want to put a bulky dressing, which just means it's going to be a big dressing that applies a lot of pressure to that entire area of the flail segment. And the flail segment just being that area of the chest wall that is fractured. So a patient can hold a pillow. You can use a bunch of Curlexes. It doesn't really matter. We just want to have some sort of bigger, bulky dressing that holds those ribs in place. So when the patient breathes, that segment isn't moved back and forth. Pulmonary contusion should always be suspected with a flail chest. If there was significant enough of trauma to cause 2 or 3 broken ribs, well, it's probably enough trauma to cause some damage to the lung tissue itself. If those alveoli become filled with blood, they're not going to be able to exchange oxygen very well, and you're going to see hypoxia. But just like pretty much all of the other chest injuries, we're going to support those ventilations, take them to the hospital. There's just really not much we can do. Sternal fracture. So the sternum, based on where it is in our body, if there's a sternal fracture, you can guess that there was a significant amount of trauma in a pretty bad area. So if there's a sternal fracture, definitely be worried about a pretty serious patient. Clavicle fracture, You could have some damage to the neurovascular bundle, which lies right underneath the collarbone. And so this is something you need to keep an eye on. Now, granted, you could have a broken collarbone that stays local and doesn't have any lung involvement, but you just don't know without an x-ray as far as how bad the fracture is. So even with a collarbone fracture, we probably are going to want to take this person to the hospital and get checked out. Now, traumatic asphyxia. So this is going to be basically, asphyxia just means suffocation. So you're going to see descended neck veins, cyanosis of the face and neck. So that just means the area is going to be bluing, just showing that there's some lack of oxygen. And you can also have this from a sudden severe compression of the chest, rapidly increasing the pressure. And like I said, the chest system is based on pressure. So if we do any major changes to that system, we're going to have some damage. Now, so this can be from like hanging or someone choking someone. It's the same idea where there's some injury to the chest wall or to the airway, and we need to support the ventilations and respirations and take him to the hospital. You can have a blunt myocardial injury, which is just bruising of the heart muscle. The heart may be unable to maintain adequate pressure, and that you can see that with that Beck's triad. So there's some sort of insult to that organ system, and you might see an irregular pulse rate and some chest pain and discomfort. When in doubt, just kind of assume there was some sort of blunt trauma to the heart. Worst case scenario, that you are very paranoid and you take them to the hospital for full treatment and there isn't an injury to the chest or specifically to the myocardium, well, that's okay, you were just being careful. However, if you miss this, if you assume it's okay and you don't evacuate this person, they may actually have some sort of myocardial injury that may not present immediately. So really anything in the EMS world, we call it neck to navel. So anything from the neck to the belly button, we're really not sure how much damage it caused. So any sort of blunt or penetrating trauma, neck to navel, we really want to evacuate that person for further guidance. Now, commotion cordis, this is kind of a random one, but it's something that's happened enough, they made a name for it. So basically, it is some sort of impact to the chest during a critical portion of the heartbeat. And really, the heart can basically jump right into ventricular fibrillation because of that impact. So an example would be a softball player. That's always what it is for people in your age group, is someone's playing some sort of contact sport and they take a baseball or a softball or a football right to the chest, right when that heart is in the middle of their contraction cycle, and the heart basically just will spasm. Now, the good news is, for the most part, these patients don't have some sort of underlying cardiac issue. So if we can take that AED and shock them back into a correct rhythm, these people usually recover pretty well. So I can attach a video. I'll send it out on the Teams thing, but there was a high school athlete who was hit in the chest and the heart stopped immediately because just bad luck, that impact occurred right in the middle of that cardiac cycle. So do CPR, get that AED on board, and usually these patients can respond well, especially if it's in some sort of non-traumatic impact like a baseball or something like that. We can usually recover these patients pretty well. So the main focus of our chest injuries lecture is going to be the pericardial tamponade and the tension pneumothorax. So just make sure you know the difference between those two. And be familiar with a hemothorax and a simple pneumothorax. But basically, it's going to be some sort of chest trauma, and how does that affect our vital signs, and what are we looking out for? So in your notes, just focus on a pneumothorax, hemothorax, and a pericardial tamponade. And just be familiar with Beck's triad. You may see that on the National Registry. However, all of these injuries are the same in that we need to really prioritize ventilation or respiration and then evacuate them to the hospital. There's just not much we can do at the pre-hospital. So that was your quick, brief lecture on chest injuries. It's relatively simple. It's going to be, if there's an opening, cover it with an occlusive dressing, evacuate to a hospital. If there isn't an open wound, stabilize that injury best you can, evacuate to the hospital. So in a way, it's easy because there's just not a lot we can do at the EMT basic level. So let me know if you guys have any questions.